The treatment options for co-infected individuals are pretty much the same as they are in mono-infected individuals. The problem was with interferon and ribavirin, the study showed that the response rates in co-infected patients appeared to be lower than in hepatitis C mono-infected patients. And until recently, those were the only FDA-approved regimens. We have had experience with the first generation protease inhibitors, telaprevir and boceprevir, and studies have shown that the response rate in co-infected patients can be similar to response rates in mono-infected patients. Problems, however, is that these first generation DAAs, or direct antiviral acting agents, have a lot of additional side effects, and so that also becomes a problem. And some of the, although initially there were some concerns about drug-drug interactions with some of these first-generation protease inhibitors with the HIV regimens, that doesn't appear to be a problem. But again, those drugs are not FDA approved. So even though we've been using them, at least in clinical trials and sometimes outside of clinical trials, the problem is that they're expensive, that they do have additional side effects, they may have drug-drug interactions with current HIV regimens, and they're not FDA approved. So that all changed with the approval of sofosbuvir. So whereas based on not huge numbers of patients, but the FDA did approve peg interferon, ribavirin, and sofosbuvir for co-infected patients. And with that regimen, there's very, if any, drug-drug interactions. And so currently in 2014, I would say that would be the standard of care for patients. Moving forward, with interferon-free regimens, there are ongoing trials with those that are being done in parallel with some of the mono-infected trials. The problem, though, is that there are more potential drug-drug interactions. And so, for example, in the Gilead's ON4 trial, the sofosbuvir and ledipasvir, you are limited to what HIV regimen that you can take. So, and typically that trial does not include patients who are taking a boosted protease inhibitor for their HIV. And so that sort of limits that particular regimen in that population. With some of the other trials, there's a BMS trial that does not limit the HIV regimen. So some of these interferon-free regimens are being used, but they're a little bit more limited to what HIV regimen that the patient can be on, at least at this point. So I think there are some things that we look at. Certainly we want to make sure that the HIV is well controlled. We want to make sure that the HIV regimen that the patient is taking now is going to be compatible with what we want to use for their hepatitis C, and that there are no drug interactions. I think that's initially a concern. I'm not sure that's going to bear out with future trials and future experience, where I think they'll be a little bit broader. I think that does the patient need to be treated is a big issue. As we know, these drugs are very expensive. And so the question is going to be, are patients really going to benefit? So I think you have to look at the comorbidities of the patients and make sure that they're going to live long enough to benefit from the high sustained response rates that we're receiving. And then compliance is a big issue. And my experience with many co-infected patients is that sometimes they just need a drug holiday, and they stop their medications for a variety of reasons. It could be personal choice, it could be imposed on them, for example, if they get incarcerated for some reason and they don't have access to their medicines, especially if it's a local jail. Sometimes they come off their medicines that way. So if they're going to be treated, adherence is a huge issue. And we want to make sure that those patients are going to be able to adhere to the drug during the treatment, that time period.